Welcome to All Things Policy, a daily podcast by the Takshashila Institution. We are a bunch of policy nerds based in Bengaluru, and we like bringing fresh perspectives to Indian affairs and Indian perspectives to global affairs. So grab a cup of coffee, sit back, and join us for today's chat.
Hi, I'm Sarthak and I welcome you to All Things Policy. In today's episode, we are going to talk about the healthcare system for India's veterans. Why is there a need for a healthcare system for the veterans? What does it look like in the Indian context? Does it meet the veterans' unique health requirements? What improvements are necessary? We are going to discuss all this. And for this episode, joining me is Major General Dr. Ashok Kumar. He's a distinguished Kargil War veteran. He is currently the Director General at Center for Joint Warfare Studies. Previously, he has served as the MD for Ex-Servicemen Contributory Health Scheme, and he has extensively studied veteran healthcare systems, not just in India, but across the globe. In fact, he holds a PhD on this subject. Welcome, Major General, to All Things Policy.
Thank you, Sarthak. Thank you very much.
Yeah. So, Major General, before we discuss the healthcare system for veterans, I want to go one step back. I have this thought, rather a question. What makes it necessary to have a healthcare system that specifically tends to veterans? Do they have some specific, unique health challenges?
Absolutely. This is a very, very important aspect to know because only then the necessity of ex-servicemen contributory health scheme will be understood and appreciated. If you see the entire Indian population, it's spread the socio-economic systems. There are a lot of disparities within various geographic regions. Even that is a challenge at the national level to provide the requisite healthcare support to one and all. Uh, Now coming to the veterans specifically, it is more specific in their case because after joining the defense forces, they serve in varied kind of terrains. They serve in plain areas, they serve in high altitude areas, they serve in mountainous terrains, riverine terrains, sandy terrains, that is deserts, and also in glaciated terrains. Most of the time they are away from the families, and therefore the psychological aspects also get built in, and there is tremendous amount of demand from them, physically, mentally, emotionally, because of the nature of job which they undertake both during the war or warlike situations or the CI and CT situations which are prevalent in Jammu and Kashmir and which were otherwise prevalent earlier in Northeast, which is now improved condition. So therefore, the defense veterans and their dependents, they need a different kind of ex-serviceman scheme. Frankly speaking, the nation has a covenant with the soldier. Soldiers join the defense forces with willing commitment to lay down their life. Some of them lose their limbs or even become paralyzed for life and get multiple ailments in the line of duty. And this can be only handled by the dedicated healthcare support system, and they cannot be treated just a run of the mill after the duty is over. Because if there is a cared kind of system prevalent, then that affects the motivation of the soldier positively. I'm sure you would have heard that we in defense forces bring even our dead at the cost of our life back, because the soldier, when it goes to the war, he knows that his comrades are going to give him the due respect even in their death. And therefore whatever structure we formulate as a national policy post retirement, that also keeps the soldier motivated, that he showed that even if he's alive or if he develops some kind of ailments, the nation is going to look after as per its need, not only for him but for the family members as well. So therefore there is a need of a specific scheme for defense veterans, and this is a practice which is there in most of the leading countries of the world, especially where they are deployed in multiple warlike conditions. Like you take the case of USA, there
Yeah, I
soldiers.
just wanted to come to that, right? So, since you mentioned that soldiers typically have a different kind of equation with the state, with the nation state. So, I was wondering, this kind of mechanism will also be there in different other countries, right? So, could you just give us some idea about the healthcare system that exists in some other countries, for instance, in the United States or in the United Kingdom? Uh, And if you can give us some specifics, right? For instance, how are these healthcare systems funded? How it is delivered? What is the extent of coverage? That will be helpful.
Okay, definitely. I shall cover the healthcare system of United States of America because it is the oldest, it is the largest, and it is the best in the world as of now. In fact, the ECHS of India has been largely been modeled on the US healthcare system itself. Of course, there are large gaps which we shall cover in the discussion as we go ahead, but that is the best system in the world. In fact, it started way back in 1865, and then thereafter it has moved with different states of taking care of their soldiers. But today, as it stands, it is a veteran healthcare administration, the Veteran Health Administration (VHA), which takes care of the veterans in USA. This is a separate ministry by itself. And let me tell you the strange thing that in case of United States of America, the veteran health is not under Ministry of Defense. It is a separate ministry by itself. That basically speaks of nation what kind of importance they accord to the veteran health care. What kind of respect they give to that. As far as funding is concerned, largely it is funded by the government of the country,
US.
but they also have a co-pay system. Co-pay system means that the based on the nature of ailment or nature of the priority of the membership and the paying capacity, some part of the expenses are borne by the individuals also, which is not in our case. In our case, it is if you are member and eligible, then it is totally free, irrespective of your state of income. So in USA, what happens that they have eight kind of membership schemes. Priority members 1, 2, 3, 4, 5, which are dependent. Whether the ailment has come during the line of duty, what kind of suffering has been done, what kind of medals one has achieved, and things like that. So if it is service related ailment, then it is totally free of cost, and the income linkage is not there. That is, entire thing is borne by the state. Second, but if it is a non-service related element, it is something like lifestyle related element. In that case, if you have the paying capacity, that if your income is more than the national income, in that case, part of the expenses you pay, even that has been laid down that whosoever is going to pay 25%, who is going to pay 50%, or who is going to pay 75%. So that is also laid down, and so therefore, a person who is even going to pay is not the one who cannot afford that. So the affordability of the national income has already been fixed, and this affordability is not only let's say suppose you are in Washington, you
Hmm.
have one kind of expenses. Suppose you go to New York, and if there the expenses are
The
higher,
expenses will be different.
so
Yeah.
though that is the national income is adjusted accordingly. So anybody, irrespective of place of stay, whatever be the national income, thereafter adjusted to the place of expenses. And then if you are earning more than that, then you do the co-pay system that the part of payment is done by you.
Yeah. So basically, part of the funding comes from the budget, and a part of the funding comes from the individuals. The co-payment takes care of that.
So I will say around 90% plus comes from the government, and marginally comes from the individuals, but that
Hmm.
has been factored based on income, so that the it is a win-win kind of
Hmm.
situation. But another thing is that they have got own setup. In fact, if you search the database, you will find if there is a patient, emergency patient, if he is rushed to the veteran healthcare support system in their hospitals, his chances or her chances of survival would be much better had he or she would have gone to a civil hospital when based in the United States of America. That is the kind of credence which is there for the Veteran Healthcare Administration there. They have their own veteran hospitals, they have their own medical colleges, they have the comprehensive research and study. They look at the changing nature of the ailment patterns which the soldiers undergo, and including the traumatic effects of this thing. Let's say suppose somebody has got deployed in Iraq or elsewhere, once that person comes back, so they undertake the research based analysis and then modify the support system accordingly. And another thing is that a fair amount of responsibility in their case is given to the veterans. In their entire dispensation of the healthcare system, veterans are co-opted at all stages. Whether if they have to be providing the ambulance, it will be the veterans organizations, and everything is predominantly being done by the veterans. And there's the social system is also very very strong. Just imagine if you have somebody, whether your parent, mother, father, at home, and that person is immobile. See the kind of effort the caregiver takes to look after that person. And if that caregiver gives this for a few years, you'll find the caregiver itself will become a patient. So in their case, they have a social system wherein the caregiver is also given at least a month's break in a year, where the other people step in and to take care of that veteran elder, and that is rotated. That is a quite willing and robust system which they follow. And they have also planned some kind of, not at par with the veterans healthcare system, but some bit of healthcare system for the caregivers also, so that that person is also looked after to some extent. So if you find look at this US healthcare system, that is very very exhaustive and very very prudent, modern, and the research input is something which must be emulated even for us.
So, Major General, this was about the US veteran healthcare system. Now, when it comes to UK, how is it? Right? Given that you have your PhD also talks about UK's veteran healthcare system, and then you are also mentioning that our current model, Indian Armed Forces, have been modeled along the lines of the UK Defence Forces. What are some of the interesting points over there?
Okay, thanks, Sarthak. But what I need to highlight that though we have a lot of British legacies in our defense forces, so to that extent we have taken a lot of practices. But I think I highlighted somewhere it might have got missed out that the veteran healthcare system in India is not based on the UK model. It is based on the US model largely. So that is the point of correction I wish to highlight.
Yeah.
But the we have also studied UK because the practices are quite common, and our current system before we adopted ECHS were based initially from the British system. So when we were part of British India, so Britishers were taking care of the those who were serving under British flag, and also some bit of the healthcare was also being extended to the veterans also. You must realize at those times and years, the healthcare system per se was not as developed as it is today. But whatever was available, that they were taking the care of the veterans to some extent. But once they moved out and we became independent, then there was a total lack of healthcare support for the veteran community and their dependents. In fact, it almost became non-existent in India, and we depended on the national healthcare system in terms of the primary healthcare centers and other issues which were available to any other citizen of the country. But since this need was very much pronounced, so therefore the defense forces themselves, extended this support from the military hospitals to the veterans within the existing capacity. But the military hospitals were located only to certain areas. If
Yeah.
you see in the western part of the country, northern, you will find more number of military hospitals because the military cantonments were those many numbers. As you go to the central India and further down south, the numbers used to shrink. But the veterans belong to the entire country, frankly speaking. And therefore, there was a huge challenge, and of course, the capacity was also a constraint. And most of the military hospitals, which were smaller in nature, didn't have the kind of the medical support which is needed by this aging community of veterans, really speaking. So the Army Group Insurance came up with a model that, especially the serious ailments like cancer.
Yeah, Major General, just can I interrupt for a bit? Since you mentioned aging defense personnel, they have some specific health issues. Could you just highlight what are some of the specific health issues among the elderly from the defense forces because of the kind of services, because of their posting and all those things, right? Maybe they would have been exposed to certain kind of things which have an implication at an elder at a later age. Is there something that we see?
Absolutely. See, since they have served in most of the cases in rarefied atmosphere in high altitude areas, So a number of them develop cardio related issues. Most of them have got the knee related issues, the arthro related issue requiring knee replacements, and also the PTSD is another thing, traumatic things which affects in their case. And the way the families are now spreading out and becoming nuclear, so that the emotional gap is also emerging, and the emergence of cancer and cancer related elements are also there. So they are, and what is a special part, that since initially they are exposed to the good health and good living practices, so they have got prolonged life. And with good medical care coming in the market today, the life longevity can be increased. And today, in fact, there is a situation that each and every part of your body can be changed, and the longevity is increasing. More is the longevity, so certain part of your functioning gets compromised. You require at times even hospice support. Even the requirement of the hospice in case of the aging veterans increases substantially. So there are specific needs of the aging veterans which need to be factored.
Yes, and these facilities are usually not available in the medical facilities which are there near the cantonments.
They're limited in number, but there are certain towns. Once I discuss with you the formulation of ECHS and how that delivery of the healthcare is being done, you realize that the metro cities like
Yeah.
Delhi NCR, Chennai.
In fact, you can talk about the ECHS model. How does it look like right now?
So the metro cities don't have much of a challenge, because the ECHS primarily has got only the ECHS polyclinics, where it delivers the basic healthcare system. It has got the normal medical officers and medical specialists, and thereafter, and it delivers the medicines as required. Thereafter, it depends on the service hospitals if they are co-located, and then it has got a range of impaneled hospitals in the city, and then the people are sent and given the treatment there. So the impaneled hospitals or the modern medical facilities, they are also not equally spread in the country. They are also focused on the metro cities predominantly, some bit in tier 2 cities, but the smaller cities, especially the higher kind of the ailment treatment is non-existent even for the civil people. They have also to, if you go to AIMS Delhi, you'll find people from any part of the country rushing and queuing up. Similarly, in the hospitals like Medanta and elsewhere, people from all over country are coming, because here the facility is there. The challenge is only the affordability for the now common people who are not having support of a particular facility. And for ECHS members, the challenge is not there. But it is benefiting only those who are sitting and staying in and around metro. Those
Okay.
who are from up, they have a
Yeah.
serious challenge towards that.
Yeah. So, Major General, if I have to go one step back, right? The ECHS you're talking about, ex-servicemen contributory health scheme. So, those who have worked for the armed forces, how do they get enrolled? Is it an automatic enrollment, or do they have to contribute some amount of money? How it is funded? Can you just shed some light on these things?
Definitely, definitely. In fact, I will take you the to the previous communication when I was telling that there was a problem of the veteran healthcare, and then Army Group Insurance, stepped in basically to take care of the serious issues like cancer, cardio, and they started giving some kind of financial support. So that got managed. Meantime, the military hospitals were also coming up. Some export, support extended from them also, but still it was nowhere near what was needed. So there was a lot of effort. Even the cases were moved to the Supreme Court, and but finally the government that point of time introduced this ex-servicemen contributory health scheme from 1st April 2003, and from that date it is a mandatory scheme for all the retirees. Without, I mean, you don't have a choice. You have to become a mandatory member, and the mere fact that its name is ex-serviceman contributory health scheme, so everybody contributes. So let's say in case of the current contribution, an officer, irrespective of rank, on retirement, he contributes 1,20,000. The JCOs, they contribute around 67,000, and the NCOs and below, they contribute 30,000. This is one time contribution, and thereafter it is not repeated, and the membership continues till the time they remain alive. It is extended to them to their wife. In case of wife, even the income criteria is not there. She may be earning 5 lakhs per month, but she is still eligible. And then to the children and parents if they are dependents. Now here also there is a criteria of dependent in terms of the economic terms, and that criteria is that they should not be any more than 9,000 rupees per month plus DA as equivalent. So that is the value which is coming. So they should be earning below that. Of course, I personally think that this threshold for the healthcare is very very minimal and not fair, but that is the government policy not only for the defense personnel but all across. So to that extent it is fair of being inequitable, and with every pay commission that gets revised. So hopefully as and when the eighth pay commission comes, this will go upward while but healthcare per se, if you see, for the defense veterans and also for the citizenry of the country, is something which the nation must assume the responsibility. Now you would have seen that the government has announced the healthcare scheme for elderly people of 70 years and beyond. And the best thing which they have done is that they have delinked the income criteria in those cases. The Ayushman Bharat Yojana, which came for the masses, but that is related to the income criteria.
Yeah, some 5 lakh or some, yeah, a certain kind of thing, and maximum 5 lakh is the, I think,
But for
family
70
cover.
years and beyond, there is no income
Hmm.
criteria.
Yeah.
Honestly speaking, a nation could be an ideal nation when it can bring a healthcare stream for entire population, uh, preferably without any linkage to any income criteria. Because if you can preserve the health of your people, then you are, actually building up your nation in a big way. So that is how the dependency comes. So each person, based on his or her place of stay, they enroll. There is a ECHS polyclinic in majority of the districts. Covering it is covering at this point of time more than 50% of districts in the country, and the number of polyclinics in a district may be more also depending on the size of the ex-serviceman population. If the it is depending on how many ex-servicemen are staying in that particular district, and accordingly the location and the number of polyclinics are decided. There were 433 ECHS polyclinics in the country. About 15-20 days back, 21 more have been sanctioned. So the coverage is increasing.
And these polyclinics are again run by the government, or is it
No,
by
so
private entities and managed by? How is it like that?
the ECHS polyclinics are managed by the government. They have a YC polyclinic who is a retired.
Managed as well as owned by government. Everything is
Yes, yes, yes.
complete. Yeah.
Yes.
Okay.
But though in the ECHS polyclinic, you'll find all the employees are contractual. But
Okay.
their pay is given by the ECHS, and ECHS is budgeted by the government Ministry of Defense. So it is the
Okay.
government of defense which is budgeting. They have got a YC polyclinic who is a ex-officer, and they have got the medical officers and specialist medical specialists, which is a mix of the retired army veterans and the civil doctors. They are due selection process, and the entire staff who is there in terms of pharmacist, nursing assistant, the clerical staff. Everybody is a contractual. 100% is contractual staff, and that is how then they have a fixed pay system. And the pay is based on what is available to the staff of the central government health scheme. Actually, CGHS is the mother scheme of all other government schemes. In case
Hmm.
of defense, ECHS or the railways or any other central government health scheme, so to say. So that is at the base level, which is a person, let's say suppose has got fever and any problem, the first port of call is the ECHS polyclinic. Thereafter, depending on the requirement, that the person can be referred to a service hospital if that is co-located, or that person can be given a referral to an imperial hospital in that particular town. Now, initially, the name of hospital used to be entered in the referral, so there were
Hmm.
some kind of unfair practices also were
Practices.
prevalent. But now the what system has been made, that the referral is given for a particular support, and it is up to the individual, the veteran, to go to any empanel hospital whom it feels appropriate. It goes there, and then the documents are digitally linked, and then thereafter, whether it is a OPD consultation or any lab tests or the hospitalization, the subsequent management is done. In fact, now it has been liberalized much more, that in one referral the treatment can continue for 6 months. And
Okay.
once a person is discharged, it is totally free of cost. Not even a single paisa is supposed to be paid by the individual, and the entire bill is thereafter, paid by the ECHS. They have a
Hmm.
proper system of the validation and assessment of the billing. So that is how the whole system functions.
Veteran healthcare system works right now. So you have a primary healthcare kind of setup, the
Yes.
ECHS polyclinics, and then there is an option for availing secondary, tertiary health facilities. And again, you have to do a one-time contribution, and the coverage is for
Lifelong.
lifetime, right? So again. You mentioned that there is an issue with respect to maybe equity. Metropolitan cities have some advantages. Apart from that, it doesn't seem to me that there are major limitations. But given that you have studied this system in detail and you have headed ECHS and you have also done some comparative analysis with other veteran healthcare systems, how would you rank or rate India's veteran healthcare systems? Do you see any limitations in the current setup apart from the equity issue?
Frankly, since I have studied the veteran healthcare system of USA and UK in detail, along with the Indian healthcare system, and once the issue of this podcast came, I also went into the details of Brazil and China, and
Yeah,
naturally, you also look at Pakistan as a how they are doing, because they also inherited
neighboring
the
countries. Yeah.
system from Britishers. So I have got no doubt, and I must be upfront that despite of the challenges about which we shall talk, it is best from the rest of the world except USA. USA healthcare system is far ahead, far mature, and far competent, and that is a direction in which we have to move, but with Indian conditions. We cannot be mathematically follow that, but that is the direction at which we have to move. And the basic structure of the polyclinics, the regional centers, the central organizations, the impaneled hospitals and things like that, that has been modeled on the lines of veteran healthcare system. But since they have the veteran hospitals, research centers, medical colleges, those kind of things are not there. They have been thought of at different stages, but they are yet to fructify in the Indian conditions. So I feel as of now, whatever countries I have studied, it is best in India, except as compared to USA. That is, I think that should be our benchmark, but not in a mathematical model. It must be modified to the Indian conditions, Indian challenges.
Yeah, so I have one question here, right? When you are saying mathematical model, what do you uh, imply here? And also, follow-up question on this. I just want to understand how much does US spend on their veteran healthcare system, and how much does India spend, right? Because and again, maybe United States, given that they have a extensively high GDP per capita, and India does not have that, right? India is, if you look rank countries in terms of GDP per capita, India will be somewhere around 130s, right? So because of these resources as well, maybe we cannot have a model which is like that of the US. So are you referring to this, or are you talking about, or at least at this point of time we cannot exactly replicate that model? So are you talking about this, or are you talking about something else when you say that mathematical thing?
No, I think I'm referring to something else.
Yeah.
The India spends close to 6 to 7,000 crores per year on the healthcare system of its veterans. It will be worthwhile for you to infer that the per individual expense what you have in US as compared to India is 5 to 8 times more there. But more than that, what is important that the currently when the ECHS was conceived, there were two reasons to that. Primarily two reasons. Firstly, the healthcare system which is available to the serving persons, they were bursting. They were not able to handle that kind of load,
Yeah.
because with the rising aspirations, all ranks started living in the cantonments with their families, whether in the cantonment areas or in the civil hired accommodation areas. So with them came the service persons, came the load of their dependents also on the service hospitals. So an option was to be found out. That was one challenge. And second challenge was that the veteran community, cannot be given preference as compared to serving community, because serving person has to be treated, kept fit, and they cannot be held wrong, they cannot be kept on waiting, because on that rests the entire functioning of the defense forces. Second was that the people were staying in far off places, and let's say just imagine in a village in Andhra Pradesh, if some veteran is there, he requires care support, and there is nothing like ECHS, then where that person will go? So there was a need of pan India organization, to the extent possible, to take care of these needs, and that's why ECHS was conceived. So it came as an add-on option to supplement the existing healthcare facility for the serving persons. But it was never developed, and it was not conceived to be capable of taking care of the veteran healthcare needs by itself. Because if you really see, except the polyclinics, then thereafter it goes either to the service hospitals or to the empanel hospitals. It doesn't contact for its pharmacy, that is dependent on the service hospitals. It doesn't have anywhere with all. It doesn't have its own veteran hospitals. It doesn't have the other support system to run the healthcare system by its own. But slowly, as things grew, the serving community started moving away from the responsibility towards veteran. Basically, kind of sense was fostered that the ECHS must take care of the veteran healthcare in totality, and the serving medical setup must take care of the serving persons in totality, despite they not being conceived that way and the ECHS not being empowered that way. However, that course correction has been taken for last 4 5 years, because once most of your people go to empanel hospital, your expenses also increase, skyrocketed. Whereas in case you take the treatment in the service hospitals, then there are hardly any expenses. So, because of the budget management and the spare capacity available and the desire of veterans to be treated in the service hospitals, and now as we speak today, the service hospitals all across the country are extending maximum possible support to the veteran community and their dependents as well. Of course, the overflow of that is going to the impanel hospital, really speaking. But frankly speaking, there are certain challenges. One challenge is that it has not been conceived to be independent. Secondly, the even let's say suppose the serving setup does not take care of veterans, hypothetically, even the serving community has got multiple challenges, because serving hospitals can take care of the serving persons and their families who are staying in that cantonment. But their family, let's say, suppose the large number of people are posted in field areas, though families are not staying necessarily in the cantonment area. Somebody is staying in Kerala, somebody is staying elsewhere. Even there may be based off hospitals in that particular city, but if you're serving personnel, then the process is so complicated, then the healthcare is affected adversely. Whereas in that city you may find a impanel hospitals of ECHS available. So therefore, I think one of the recommendations, we will talk about this little later also in detail, is to
Yeah.
have the integrated healthcare facility. Ideally, would be that it gets taken care of the integrated manner in totality. Like if you go to the service hospital today, which are providing the healthcare to veterans, also to serving hospitals. Now you'll find the two pharmacies. There is one pharmacy where the medicines are being dispersed for the serving community. There is another pharmacy and dispensary where the medicine is being dispersed to the veteran community. So entire system, whereas the purchase is from the government funds only. The money is coming from the Ministry of Defense, but since they're
Okay.
coming in different budget heads, and then they
Okay.
are being kept this thing committee, ordered manpower. There is so much of a wasteful approach. Once,
Expenditure.
once an integrated approach is done, of course, when once you integrate, I must accept that the priority must go in service hospitals to the serving community, but thereafter
Yeah.
it go to this thing. But this kind of segmentation of the separate accounting, separate pharmacy, and let's say suppose people are admitted in the wards. It is not practically possible to dismiss medicine that this is from the veteran pharmacy, this is from the serving pharmacy.
Okay.
And if you see the number of people who are committed in pharmacy medicine management is colossal. So, firstly, the entire infrastructure must, because both are the entitled category, both are being funded by the government, and therefore it must be integrated support. The to my mind, the medical support the must be owned by the medical services of the country, both for the serving community and for the veterans community and their dependents all over the countryside, and even in a coordinated manner. Let's say, suppose I will give you example of serving person. Suppose somebody has got a problem of heart in Meerut. Meerut is a big cantonment, but the MH Meerut doesn't have any major specialty with that. So that person will
Hmm.
go where? That person has to come to the Delhi. Before that, a serving person cannot be treated. But in
Hmm.
Meerut, you will find there are a good cardio specialists which are on the panel role of the ECHS. That person cannot be taken and treated there, and because of the procedural issue. Similarly, but there are a large number of places where the serving persons are being moved to service hospitals because they don't have this, impanel hospital setup, which in case of ECHS is, present. So therefore, even if the ideal integration is not adopted in the first stage, I think the procedural permission of each other's facility must take place. If there is a
Hmm.
serving person, his family are dependent staying in any part of the country, if there is a ECHS setup, that person must be taken care of, or vice versa. If there is a impanel hospital in a
Hmm.
town, so why that service person should be moved out, travel such much distances, be so much out of duty, that can be done there because the expenses are going to be done,
And I would assume that because you have this duplication of efforts, the cost of providing the services will also be high, and it can also be reduced if you are integrating all these things.
Absolutely. Sarthak, duplication of effort is one issue. It also strains the, healthcare.
Hmm.
A person just
Hmm.
needing the, cardio support in Meerut, just imagine though
Hmm.
Meerut is, close and now the infrastructure is developing, he can be rushed to. But there are a number of other towns where the
Hmm.
service person, normally, is rushed only to the serving hospitals. Or if he goes to the private hospitals or the, government hospital, then they have got own, Legnos. Whereas in case the ECHS and this is dovetail and the procedural permission is granted, so it will be still seamless even if it is in the current process. So the
Yeah.
integration of the entire healthcare is very very critical to address some of the concerns.
Apart from the lack of integration, any other challenge that you
No,
see?
challenges are very many. Firstly, the funding itself is the biggest challenge. Normally, when I was MD ECHS, the budget support used to be somewhere between 3,000 to 4,000 crores. And and every year we used to have a backlog, carry forward liability of the hospital's bills, which we, could never, pay. In fact, to my knowledge, there has not been a year in a recent past, for a decade or more, where you are able to clear all the bills of hospitals in that particular financial year. By the time you come reach October, November, December, your money exhaust, and then thereafter you are on the credit of the hospitals. Some of the hospitals which are sought after, they even stop the treatment of the veterans community. I have myself faced that. Medanta in Delhi and other hospitals, they refuse, and then they have to be cajoled, persuaded, and understood that it is government money which will come, and which does come, but it comes in the next year, next financial year, in April, May time frame. But once it comes, then again it consumes bulk of the budget of the
Next year.
current year, and that the cycle continues. So the scheme which was conceived, it was conceived that it will be fully funded by the government, and therefore the government must take the responsibility that there should not be funding constraint. There are certain challenges where the funding can be reduced, because otherwise funding will keep increasing, because as I told you earlier, that today each and every part of the body can be changed. So a
Hmm.
person who is knowing that he is going to be given all kind of treatment free of cost, no liability, and there is no limit to the treatment. There have been cases where the government has spent more than crores on an individual expenses. So the requirement is to focus on the preventive health care. If the
Hmm.
preventive health care is focused, at times, certain, let's say, suppose you undertake a test and detect a cancer related ailment in the first stage, then the treatment and management is much more cheaper, and it is much more effective. The government in the long run, the money it is going to spend in third and fourth stages will get reduced, and
Expense,
that
yeah.
person will have a higher chances of survivability. Similarly, so many other elements. So the preventive health care is something which has to be focused in a big way, which is currently missing. Now it
Hmm.
is a reactive model that you
Okay.
face a problem, you go to the polyclinic, then whatever test and support is required, that treatment is provided. But there is no mechanism that age wise, okay, that you have reached this age, so these are the likely ailments which take place at this age,
Hmm.
so you are screened for this thing. If something comes up, then you are treated, so that you don't go there as a blown up case. So
Hmm.
preventive health care is and the very big challenge besides funding. Of course, we have veterans, especially in mountainous regions, Uttarakhand, Himachal, Jammu and Kashmir, and elsewhere, where we require more number of mobile medical units because of the requirement of people to come to polyclinic and take a treatment. So that is not possible. That must be increased. There has to be a requirement of the procedural change, which I found an excellent scheme which is they are following in the United Kingdom. We have the system of only impaneling hospitals and labs, and now we have gone in for empanelment of some certain prosthetic centers also. But in their case, they have the system of empaneling individual doctors. Now just imagine a person in a village, he has a normal fever.
Hmm.
So the polyclinics are there in the city centers. They are also open only from 9 to 5. Of course, he in emergency can go anywhere and then take the treatment and then claim as per the CGHS rates. But there are large number of difficulties which we face in a practical terms, which are not emergency, but we require some kind of medication. So that person is deprived. But in case of
An empaneled doctor can
correct.
be closer and you can have the medical intervention quicker,
Absolutely. In
maybe.
case of UK, they have large number of doctors which are empaneled, so that you have a problem, you
Hmm.
just go take. And the regulatory framework up to what amount and what kind of thing you can avail from that to avoid that there is no
Hmm.
leakages. So that can be this thing. So that is another problem and challenge
Hmm.
which is there with this scheme. The if you also see today, when the laparoscopic interventions came in surgery, or robotic surgery came and these things, so these were not part of the ECHS process.
Initial, yeah.
So it takes a lot of time for a modern surgical and medical processes to get introduced in ECHS. So ECHS is not to be blamed here, because
Hmm.
ECHS gets what CGHS gets, because it is Ministry of
Hmm.
Health and Family Welfare which is supposed to introduce these things in the healthcare scheme. So once they implement these things in CGHS, then thereafter it comes to automatically in ECHS also. So that is there is also a huge lag between the modern facilities, and in the process people go through the obsolete processes, face difficulty, face no longer admission, run the risk of.
Some of them might also be more painful,
Absolutely,
might take more
absolutely.
time to recover.
Absolutely. So that is another challenge. Then the CGHS rates are also very very unreasonable. The not in case of all the elements. There are a number of elements where the treatment, the cost of treatment, which is claimed by the hospital and which they are paid by the government, is not realistic at all. Market rate are
They're not linked with the market rates.
correct. And you can always have a rate lesser than the market, maybe 20, 30, 25% lesser than that. That is fair enough. But it cannot be have 20, 25, 30% of the market rate. No. So finally, what happens in this, either hospitals avoid those processes, or they undergo certain unfair practices to recoup that money by other means. So that the CGHS rates have also to be realistic, in case you want that the fair practices should take place. And as I highlighted, that the best part in USA is the comprehensive research which dictates as to how the healthcare management is going to take place. There is no research in ECHS. There is a urgent need actually to establish a research center in center organization of ECHS, which is based in Delhi, which is the apex body of ECHS. so that the nature of ailments, patterns, medical and best practices, they can be researched, evolved, and then be brought into practice. So that is a big lacuna which is there. And of course, we don't have the veteran hospitals. And this is
Hmm.
something which has been thought of being tried, that there should be, at least in the major cities where there is a large amount of concentration of ex-servicemen community, rather than money going to the impanel hospitals, it can be made more cost effective if we have our own veteran hospitals. So that needs to be created. And similarly, the hospitals, as against stressing the serving community, there can be veteran wings in them. So a lot of these things have been thought of, but they are moving with a little slow pace. And of course, there are certain simple procedural issue in terms of entitlement of doctors. They are based on the number of ex-servicemen, whereas each ex-serviceman comes with 2.5 persons, in the patient load,
Hmm.
taking his family and the children on an average. So there are certain other processes, which
Yeah.
are the challenges, but I'm sure these things can be looked at.
Yeah.
Some of the
So Major General, I just have a few questions related to some of the challenges that you identified, right? One of the thing was that okay, there is always shortage of money. Maybe the whatever is the budgetary allocation, it is not enough. So again, my question is, why is it not something that the government has kept in mind, right? If there is a shortage in one year, next year it is not there. It's maybe something happened in this specific year, the spending increased, right? So it is something which is maybe that year specific. But if it is a recurrent thing, maybe the government should have increased the allocation. Or do you think it has not been a priority for the government?
No, I mean, it will not be correct on my part to say that it has not been priority for the government, because government brought in this scheme, and I told you that except USA, it is the best in the world, and it is doing a lot of good job. But the budget is something which is a serious issue, and I can't fathom as to why, despite this becoming a recurring problem, when the economy is growing in such a big way, we have already become the fifth largest economy. We are moving towards third economy. I fail to understand why we cannot take care of the budgetary support, because this budgetary support is one of the prime challenge which this scheme is currently facing.
And the second thing that I had was, since you mentioned that ECHS is linked to CGHS, and whatever procedures they decide, ECHS takes it, and there is a lag. The fares, again, whatever is mentioned in the CGHS, ECHS take it. I was wondering, why can't we de-link these things, right? Maybe ECHS can decide on its own what should be the prices for different kinds of procedures, and again, what are the procedures that should be part of this, right? ECHS cannot decide on its own. Why is it that not the case?
Well, that is for the government to
Hmm.
address that. But all the central government schemes, like
Yeah.
not only the that in defense, but even the railways, they also have their independent healthcare scheme. Everything is model on the CGHS, because Ministry of Health and Family Welfare is supposed to look at the healthcare dynamics of the entire country. In fact, it is they who have also brought in this, the norms and rates of the Ayushman Bharat Yojana of the various processes, and even the current scheme, which is for elders beyond 70 years. They are the fulcrum of the entire healthcare in India.
Got it.
So therefore, it is not that the induction of latest processes and other things are a challenge in ECHS, and they are not in CGHS. There people are suffering there also. But in case of veterans, this is the largest segment, and people have, because of their nature of work, which we initially discussed, have more higher challenges. So therefore, it is more pronounced in their case. Otherwise,
Hmm.
this is challenge all across the rates and those kind of things.
Okay. Yeah. So since we were talking about the challenges, and since we are more interested in what can be the solution, and we should not be just fixated with the problems, so I was wondering, what are some of the reforms that you would like to recommend, right? Do you see any of those challenges that can be easily rectified? In some cases, maybe it is not as easy, but again, we run the policy marathon. Maybe we can start thinking about ideas which can maybe get implemented in the long run. So what are some of the reforms that you think? should be there?
I think this is going to be the crux issue, and I must admit with due responsibility as well as my strong belief that most of these things are doable and they must be done. Number one, firstly, the government must own the scheme in a manner it was conceived. When I say that, I mean that the funding support should be given in totality. Like, we have the kind of, we provide budget to various heads. And when, it is, initially the budget estimate stage, then, you come to the different stages, go to the RE stage and all that. And that is how this also moves. But healthcare is not something which can be made hostess to a timeline. A person is ill today, if let's say suppose if you are not providing the budget, that person cannot be treated, then what is good of that money after 3 months, 4 months hence. Whereas the other, let's say suppose it is an office contingency. If you are not having funds, you may wait for 2 months, 3 months. There may be some effect on your functioning, but it is not going to be that cascading effect. Whereas in this case, it is going to affect life. I have personally been privy to where hospitals have created a lot of problems for the serious patients, and that one has to run around lies and talk and all that. Why should that situation should arise? And their demand was that the, let's say suppose each hospital, a big hospital, if their outstanding is say 1 crore, 1.5 crore, they can still manage as a recurring case. But if that increases to 3, 4, 5 crores, there will be a stage. They also have board, accountability that money will come. Then what time it is going to come. So the government first thing must come committed on the budget support. They can conduct an audit. Firstly, the expenses are all audited at all stages. They can conduct an audit, and whatever they feel that some expenses are required to be reduced, that they can take. But the healthcare portion, it is something which they must own without any second thoughts. Because if this correction is not done, the scheme will fail sooner or later. I'm telling you that if the budgetary support is not adequate, it is not survivable. So the budget support must come. It has increased. I must also say that year on year the support has increased, but it is still not to meet the entire expenses. That should be something which must be a bottom line. Second is that they must focus on the preventive healthcare. This focus itself will reduce in a 3 to 5 years substantial expenses, and that will get addressed. Initially once you invest some money in preventive healthcare, you may like that as against the reactive treatment. You are also spending something here, but this investment is going to reduce in a big way. The HR patterns also have to be changed. There is a reduced number of representation of the veteran community. There is nobody in the ex-serviceman welfare which is running this scheme. In fact, there are no medical doctors also running this. So if you are having a healthcare scheme and not somebody to give you that input, so again that becomes a challenge. Similarly, in the central organization ECHS, though the doctors and everybody is there, but I think there is a need to have some veterans also of appropriate representation. Similarly, in the regional centers which are linked between the central organization and polyclinics may in any case there is no issue. So HR should also undergo a change. The pharmacy is another thing which must be outsourced without second thoughts. In fact, it should have been done long time back. A lot of efforts were made, but somehow, it hasn't seen the light of the day. Today, the country is developed in this field in a big way. If you go and visit any ECHS polyclinic, the people are worried about the accounting of those medicines. What is being given, what is accounting, whether there is some pilferage or not, and things like that. The core concern of the medical care is getting neglected. And that is same thing is happening in the service hospitals also for the accounting of pharmacy medicine, whether it is ECHS. Otherwise, number of people who are committed there for accounting, marking, and pilferage should take place is phenomenal. Now you have the best of the pharmacies in the country which are of the world standard. So you can outsource. It will work out to be cheaper also. They'll be responsible. There'll be 100% assured supply.
And you'll have better options as
Better
well.
options, simple accounting, and your manpower on those things can get released either in terms of reducing the expenses, or the people who are there, they can be freed from their secondary tertiary job and they can be focused on their primary job. So
Yeah.
outsourcing of pharmacy, it is must. One of the thing is, CGHS is a healthcare scheme where it is for the serving persons as well as for the retired persons also, unlike ECHS, which is only for retired persons. So in their case, it is a paid model that some kind of money is paid yearly when you are in service, and that is how after retirement you pay 10 years equivalent money at the time of retirement. So once we have been modeled on the CGHS norms, it was basically to look at the norms of processes, because the treatment was a terms of condition which was free for serving persons and veterans. But just because of model, even this payment has been inbuilt. But so it's a matter of semantics, not a big issue, because at time of retirement you get money. So if you are paying that one time amount, so that is not a challenge, so to say. But a nation which takes care of this thing, this hardly adds to 3 to 4% of the kitty of the entire amount, so that could be done away with. But it's okay if it is there. Dependent income criteria I have spoken, because number of children are there. If they have got some money deposited in their bank account and the interest income goes beyond 9,000, then they are taken out of the system, which is totally unfair. Just imagine, if we have an income of 9,000 rupees per month, can we afford today's healthcare system? So this is something, the dependency criteria for other purposes and the health care purposes has to be different, not only in the defense forces but for everywhere. Health is something which must see the primacy of the a nation's concern. We I must admit and commend the government that we have been moving towards that to whatever extent possible, but more needs to be done, really, in that particular this thing. There are a lot of the elder care organizations like IMOPA and elsewhere who are working. Of course, they are the paid model, but if you find elder care organization, they must be co-opted with the healthcare system of ECHS. Even if you have those kind of setups functioning even on a paid model. So in today's time, there is a fund availability with the people after one pension. There are certain services and conveniences which they can pay and use till the time it is for their larger good. So those things should come. So veteran hospitals and veteran organizations, I have already spoken the need of having latest procedures that already I have said. I have also talked about in the process of communication about the integrated healthcare rather
Yeah.
than the disjointed effort, how that is going to be a win-win situation. And of course, the alternative medicines like Ayush has been included. It must be given more coverage in that particular this thing. In fact, when I visited a number of polyclinics in my time, some of the veterans told that you may reduce the number of doctors but keep a psychological counselor, because the after a certain age there's nobody to talk to the people to look after their psychological needs. So the total wherewithal and caring of that person has to be taken care of, and that is possible once we have a dedicated research who is looking after in this particular system. So that is the some of the recommendations I feel if they are adopted, they will be bringing the sea change.
Fantastic. I mean, thanks for the comprehensive set of recommendations. And I think you already talked about it. The American system focuses a lot on R&D. Maybe that's also something that we can think of, more evidence-based medicine and healthcare setup for the veterans. So I would assume this discussion is just a beginning of a larger conversation. Maybe let's keep pushing more meaningful reforms to ensure that our veterans receive the support they have earned. So thank you, Major General, for these detailed insights. So any concluding thought?
Uh, just that the one should be proud what the country has done, but more proud you feel of your country, your expectations also rise, because now you are not a run of the mill country. You are going to be the lead country in the world. You are planning to become a developed nation by 2047, and it is the defense forces and veteran community which are key to a nation's growth. They are the last resort of national instrument of power, and therefore the veterans must be taken care of. And besides pension, healthcare is the second most important thing which affects them. So I think a constructive support by the government on all these issues which we discussed will go a long way in changing the profile of the organization.
Thank you, Major General. Thank you, listeners, for tuning in. We will meet again in one more episode of All Things Policy.
Thank you.
If you liked our show, dive into Takshashila's research on technology, strategy, and economic affairs. Check us out at our Twitter handle at Takshashila INST or our website takshashila.org.in.